Welcome to another episode of the PFC podcast. The opinions you hear are ours and doesn't necessarily reflect anyone else's. Now on to the podcast.
So, thanks for inviting me. I will probably not make it in 25 minutes, probably use a little bit more. I've already told the people. This is my personal opinions coming up on these slides. My disclosure is Mother Nature. I'm not funded by anybody else. I'm just giving a short introduction to the network. It's kind of an international multidisciplinary network. We have more than 232 members at the moment from 18 different countries and 4 continents. It's all from basic scientists to translation investigators, bedside physicians, frontline medics, and civilian paramedics. So we try to kind of bring together the end user and the researchers and the clinicians in the same crowd. So this is our mission. So it's all about, we should even say, a pre-surgical resuscitation of traumatic hemorrhagic shock. And traumatic hemorrhagic shock is what we used to call, when we say coagulopathy, we changed, or I think it's a better word to say blood failure, because that is what it is. We could have a whole lecture on blood failure. This is the steering committee that we have at the moment. We keep sometimes changing people on this, but me and Phil, so far co-chairs, started this in 2011. So just to remind you that when I started this, the first conference, so I'm used to people making jokes on me. That's no problem. I have no problem with that. So this was a professor from the UK Helicopter Emergency Services who had a lecture at our conference, and he started with this slide. And he said, because we started looking at whole blood, partial blood, and reinfusing and stuff, and he thought it was completely crazy. So it's not that crazy anymore. So I think for all things we do on the battlefield, understanding physiology is probably the most important thing that you do understand, because you need to understand why you're doing this to accomplish that. So I will talk a lot about physiology. This is just for, as easy I could stop this lecture now and say that blood is for bleeding and salt water is for cooking pasta. This is actually Phil Spinella's words, and he's Italian, so he cooks a lot of pasta. He also is a fan of using blood for resuscitation, as very many other people are. So I'm going to talk to you to kind of see where this fits into a prolonged field care scenario, because you have traumatic hemorrhagic shock, and what you need when you're in shock, you need a surgeon, ASAP. So, but the problem is you don't have one. So then how should we deal with this casualty when there is kind of 6, 7, 9, 10 hours to a surgeon? So who has the best possibility or chance of survival? And do these protocols we have discriminate between hemorrhagic shock due to a compressible bleeding that you control versus ongoing torsal bleeding? That's 2 different things. So probably if I would go for any one of those, I would take the hemorrhagic shock with a compressible bleed that you have been able to stop. Then you probably could keep that guy alive for a significant amount of time, as long as you don't apply permissive hypotension. So I'm going to talk a little bit about the permissive hypotension approach, and also go back to the Bickle study that actually started this, but it doesn't show that a permissive hypotension is a good thing. It just shows that saline doesn't work. So when you're talking about prolonged field care, this slide worries me a bit, because you see where people die. So where are the guys you're going to treat for 10 hours in this curve? So what we need to say is that shock treatment early, or maybe even before reaching shock, might be a good idea. And I'll show you why. So the problem is, how much time can you actually buy, and how to buy that time? And I don't have all the answers, I guarantee you. I have some thoughts on the physiology, but I'm not giving you the straight answer to this, because I don't think we have the answer yet. But this is some of the problems you meet. So we always talk about avoiding popping the clot. So that is systolic below 90. But what about coagulopathy? Do coagulopathy pops clots, you think? Well, that's a big clot popper. But can you avoid shock when you have systolic below 90? So do everybody agree that we should reverse hemorrhagic shock on the battlefield? Who would agree that resuscitating people and reverse hemorrhagic shock pre-hospital should be done? Anybody who thinks that's okay to do? How many of you would say that, yes, hemorrhagic shock on the battlefield should be reversed as quick as possible? How many? Come on, up with hands. Say if a spontaneous breathing casualty with ongoing bleeding has systolic blood pressure of 80 to 90, have you reversed the shock? Yes or no? No. No. Okay, then we have a problem. Because you treat coagulopathy, if you treat shock, you treat coagulopathy, so treat shock early by giving whole blood, and we could stop now. But I'll go further on with this, because I could talk a lot about platelets, because we need to understand that not only blood is important, everybody knows what the platelets are used for. I mean, platelets are good for clotting. If the platelets are going to have a platelet party, there needs to be some platelets there to have that party. It's not going to be any fun, but there's no platelets there. We have been also looking into stories of platelets and doing cold storage of platelets, and I think that's going to change the way we do things, that we can actually deliver platelets to the battlefield from home because we can store them cold. So this is basically, everybody knows that shock is bad for you, but the dose of shock is correlated with outcome. That is a very important thing to remember. So dose of shock is correlated with level of coagulopathy and level of inflammation. So the more you are able to reduce the shock dose, the better it goes. You don't want coagulopathy because you want the blood to coagulate. Because you bleed more if you're coagulopathic. So here what we need to do. So I hope you understand what this balance is. So the guideline says keep systolic between 80 and 90, but we don't know if we have reverse shock by having systolic blood pressure between 80 and 90. And if you're in shock, you are actually acquiring coagulopathy, and that's the problem. So is there any way we can do this? So I want you to know that you have to know about the fixed equation. What is actually oxygen delivery? Oxygen delivery is a three-factor. It's hemoglobin, cardiac output, and arterial oxygenation. That is mostly important to understand. And a lot of guidelines says something about threshold for hemoglobin. I'll tell you, hemoglobin matters. And it really matters when you're in shock. I mean, it's impossible to survive shock with a hemoglobin of 7. I mean, you could figure it out by fixed equation. Just put the numbers in there, and you see that will not work. So this is what's happening. So DO2 is decreasing. Slow mentation. Is mentation a good sign of shock? I mean, if you've given ketamine and Versed and all that stuff, maybe mentation will not be that good. Increased respiratory rate due to lactobacillosis, yes. Tachycardia, a lot of patients are tachycardic without being in shock, and not all patients in shock are tachycardic. Cold and climate, well, a lot of cold and climate patients without being in shock. And urine output reduced, of course. Urine output is reduced. I mean, that's normal. Even if you don't bleed, if you get hurt, you bleed less. You pee less. So the most thing that keeps me awake at night in the ICU is urine output too low. Weak absent pulse. So how many in this room would guarantee say that I can feel a pulse of a casualty with a systolic blood pressure of 85 being hyperperfused? Have you tried it? Could you really feel that pulse? So maybe we need something else. So also remember that pressure doesn't tell you anything about perfusion. It's a bad matter, because you can have systolic 90 and cardiac output of 7, and you can have systolic 90 and cardiac output of 3. So in these casualties we're talking about, you have a high systemic vascular resistance keeping the blood pressure up, but you can still be in shock with a systolic of 90, no problem. So this is a three-edged sword, I see it. So because avoid popping the clot by keeping systolic blood pressure below 90. And if you have TBI on top of that, so most guidelines doesn't really deal with TBI. It's too difficult. So we say TBI, yeah, just keep it above 9, and we don't talk about that anymore because it's too difficult. So resuscitation of people with TBI, how do you actually do that? I don't think I have the answer, but this is going to be a topic at this tour conference. So avoid coagulopathy blood failure. But to acquire coagulopathy, you need trauma and systolic blood pressure between 90. But that's what the protocol says you should do. So permissive hypotension is a problem in a prolonged field care setting because you die due to shock dose too high. That's what you die from. So how do we do it? So I'll tell you, permissive hypotension is not a treatment. It's a hemostatic procedure. A hemostatic procedure, but you cannot keep on going for too long with that hemostatic procedure. So it's not a treatment. Necessary evil for a short period of time, yes. Evidence? Where's the evidence for permissive hypertension? Really? Well, the Bickel paper was the first, but as I told you, that is not a proof that permissive hypertension is a good thing. It's a proof that crystalloid is a bad thing. Because they compared crystalloid versus nothing, and doing nothing was better than crystalloid. So what does that prove? It proves that crystalloids are bad. It doesn't prove that hypertensive resuscitation is a good thing. So the Bickel study should be done over again and compare with blood products and resuscitate to systolic 100 versus crystalloid versus nothing. I think we had it. That could be an interesting result. So this is, what about delayed evacuation? So how long can you be in low flow state? I mean, there's a lot of animal data on this. You don't survive very long in a low flow state. This is mean survival 2 hours, a mean survival 3 hours, significantly shorter survival in the hypertensive group, and so on. So the animal study is kind of telling you that you shouldn't keep on this for too long. So what targets? So this is the E-TRIS paper showing that systolic 100, that is kind of the limit for death on the battlefield. So why don't we say systolic 100 instead? Easier. 100. And this is base deficit. And remember, if we measure in the emergency room and find the patient is coagulopathic, he will also have elevated lactate and bad base excess. So if there is normal lactate on admission, you're not coagulopathic. You need to be in shock to acquire coagulopathy. So there's a couple of definitions about shock that you will know, but we have to talk a little bit more about oxygen delivery, oxygen deficit, compensated shock. So oxygen requirement is beyond oxygen supply. That is really what the problem is. So you actually get delivery-dependent oxygen consumption. So your oxygen consumption goes down, your metabolism goes down, not because your metabolism is going down, because your cells doesn't have enough oxygen. So oxygen is the problem. So oxygen deficit is the difference between the metabolic demand and supply at a certain time. That is a snapshot of the shock. If you multiply that with time, you will acquire what we call oxygen depth. So that's the time spent below critical oxygen delivery. And I'll show a couple of curves on this one. So you've probably seen this curve a lot of times. I'll try to explain it to you. So as we sit here in this room, most of you have like basic metabolic demands. You probably consume about 280 cc of oxygen a minute. But your body has been delivered 1,100 cc of oxygen a minute, so you're luxury perfused. You only use 25% of the oxygen that is delivered. So if we now say this is VO2 on the x-axis, DO2 on the x-axis, and oxygen consumption here, you meet the critical. Sorry. This is the critical point here. So you really don't want to be to the left of that curve. You want to be on the right side, okay? So this is death. So the longer down you come here, the bigger the oxygen deficit, the greater in shock snapshot you are. So I'm taking this because what we need to understand, people compare pre-hospital and in-hospital damage control resuscitation. In hospital damage control resuscitation, people are anesthetized, ventilated, they have a lot of drugs. You can keep the systemic vascular resistance low and have a higher cardiac output to a systolic blood pressure of 90 compared to pre-hospital. Pre-hospital, you're awake. So you probably have increased baseline oxygen consumption when you're agitated, in pain and stuff. So you reach the critical DO2 level sooner compared to when you're in general anesthesia. So, meaning that I'm just comparing you now to, so this is baseline normal again, and this is when you're in anesthesia. Your VO2 is reduced, and you shift the DO2 critical to the left, meaning you actually don't need that high oxygen delivery rate. So we need to understand that you cannot necessarily compare damage control resuscitation that is actually going hand by hand by damage control surgery. When you do this in the field with a awake, agitated patient, it's a bit different. So what's happening when you spend time on the left side here, that you're actually acquiring what we call oxygen depth. That is important to understand what that is. I tried to explain it. So when you resuscitate, it's not good enough to resuscitate him back to the tipping point. You need to repay the oxygen depth as soon as possible. So you have to repay it. So you have to resuscitate more than just back to the critical point. So this is another way of looking at it. So here's your point of injury with normal oxygen delivery. So you're actively bleeding, DO2 falling, you compensate, you vasoconstrict, you get tachycardic and stuff like that, you increase your oxygen extraction rate. So when you're below the red line, you're anaerobic. When you're above it, you're aerobic. So when you pass the red line, you're in shock. So then there is a certain amount of time before you kind of are able to start resuscitation. So probably use some time, okay? You resuscitate, and the dose of shock is kind of the area under the curve. So what you're trying to accomplish here is you have to spend as little time as possible below the critical line under there. So the problem is when you're doing permissive hypotension is that you don't know if you're under the curve or over the curve. So we probably need something more than only blood pressure measurement. So maybe this is the way we should do it, especially when it's going to be more than like 30 minutes or 60 minutes to the surgeon, that you should maybe allow the casualty to be permissive for a certain amount of time, so that the clot can strengthen and maybe chance of popping that clot is not that big. So at least you need some time for strengthening the clot. It takes some time. And then after a while, you just have to resuscitate a bit more. And where is that level? Is that a systolic 100? Or could we use something else to help us out with knowing that we actually are doing the right thing? So we've introduced the point-of-care lactate. This is a lactate monitor. It's for sports medicine. It weighs 45 grams. It takes 15 seconds to measure a lactate. So lactate is actually predictive of poor outcome in the hospital setting, and there's a lot of studies showing the same pre-hospital. Actually, measuring lactate and lactate trend could be an important thing to do to know if you're doing the right thing or the wrong thing, because if your lactate is trending higher and higher, you guarantee not doing it right. You have to change your strategy if your lactate is increasing over time. So this is the minimum equipment you need if you're going to do resuscitation, especially over time. You need a blood pressure cuff, because you cannot rely on just feeling the pulse. And I would recommend using a lactate monitor in conjunction with your clinical eyeballing, using blood pressure and lactate. I'll probably be better off by doing that. This is one of the animal study Geir has done. This is a resuscitation over time, hypotensive resuscitation, and what you see, the accumulation of lactate is best in the fresh whole blood group. But that is explainable because you're using fresh whole blood with a hemoglobin of 13 instead of reducing your hemoglobin. So even by using components versus whole blood, there is 35% higher oxygen delivery in a bag of whole blood compared to components in a 1-to-1. 1-to-1 resuscitation gives you a hemoglobin of 9. Whole blood average hemoglobin of 13, and I think hemoglobin matters. So I'm just going to start saying a little bit about this Bickel study because the last couple of days I've been looking into what is the difference between the delayed group and the immediate group. So if you look at the numbers here, keep pushing. They have systolic blood pressure on point of injury, the same. So all the vital signs are the same in patients in both groups. It's very short response time and very short evacuation time. So it's average 30 minutes from point of injury to emergency room. That is not what we are talking about. This is really short, okay? And there's another 45 to 50 minutes until surgery. So what the study here do is the first 80 minutes, they have a different approach. They either giving them nothing or they resuscitate with saline. That's the difference. After 80 minutes, they are resuscitated the same way. So in the OR, they have the same strategy. So only the first 80 minutes. So here you see systolic blood pressure. Hemoglobin is significantly different in the delayed versus the immediate group. Here is when they start resuscitation in the OR. And you see here, what is statistically different here is hemoglobin. So if we postulate that they have the same hemodynamic parameters in both groups, meaning they have the same cardiac output over that 80 minutes time, then I've just made the mathematics with the fixed equation. The delayed group has then 3,000 cc's of oxygen delivery higher than the immediate group. So they have not the same amount of oxygen depth. And oxygen depth is the level of shock. So probably an idea would be that even if not doing nothing, their shock dose has been less by doing nothing. Interesting. Here you can see the difference between this. So the difference here is the difference is 2.2 liters of crystalloid in the immediate group versus delayed group. So you look at this one then. This is from Korea. Look at the systolic blood pressure on admission. Pretty much the same or worse than the Bickel study. But if you see the evac time, point of care, if a point of injury to emergency room is average 150 minutes. The average time from arriving in the emergency room till surgery is another 3 hours. But see here, you see the blood products used? So 4.4 liters of whole blood is used pre-surgically. So they resuscitate with whole blood prior to surgery, continue resuscitating with whole blood during surgery. And they have a case fatality rate of 21%. So this would be a good thing for flow feedback. At least they are able to keep this casualty alive for 3 hours, but they use a whole lot of blood products to be able to do that. So that is one of your problems. You're resource limited. How many blood bags do you have? And if you have more than one casualty, who should you pick? I don't have the answer to this. This is ethical dilemmas as well. It's your combat buddy. You would do everything to save his life, but you have another one here. So decision-making process here is hard. That's the only thing I can say. I need to say this. Positive pressure ventilation, guys. A lot of focus on rapid sequence intubation. Be careful. It's a lethal intervention if you don't know what you're doing, especially if you do it with someone who's hypoperfused. And remember, ventilatory requirements in low flow states are limited. So all protocol says you should normal ventilate. Why should you normal ventilate when your cardiac output is 50% lower than normal? I mean, there's go 50% less blood through the lungs, exposed to gas exchange. So why do you have to normal ventilate? If you're in shock and ventilation, reduce it by 50%, ventilate 6 times a minute. Because there's no gain in ventilating 12 times a minute, because there doesn't go that much blood through the lungs to be exposed to gas exchange. So this is what's happening. So everybody who's been working in the community with traumatic hemorrhagic shock and has intubated in the emergency room, I guess most of those who work with that have seen patient crash, even going into cardiac arrest. If you have a really bad patient and you intubate him without being able to kind of resuscitate in parallel with that, you're really in deep shit and deep trouble. So I say spontaneous ventilation is a good thing. This is Pat Thompson. He's a very smart guy. We sat discussing this and said, you know what? If you're unconscious due to hypoglycemia, do you RSI that guy? Do you do rapid sequence intubation of somebody with unconscious due to hypoglycemia? Who would do that? The treatment for that is IV glucosis. If you're unconscious due to hemorrhagic shock, the answer is not, there's nothing wrong with you. If there's nothing wrong with your airway, the treatment for unconsciousness due to hemorrhagic shock is resuscitation with blood to regain consciousness. It's not to intubate him, because you would probably make it worse. So this is another thing. We are now introducing low titer O cold stored whole blood, or even warm fresh whole blood, like the 75th have the Rollo program. So the CPG for damage control resuscitation actually mentions pre-hospital resuscitation with whole blood, linking to TCCC guidelines. People carry low titer O whole blood in the field. But the CPG for warm fresh whole blood says you do type specific. So if you start doing low titer O pre-hospital and have transfusions like maybe 4 or 5, you cannot go type specific when you do surgery. You have to continue with those. So people have to remember that, and so you lock yourself in some shape or form when you start with low titer O group whole blood. You have to, if you have more than 4 units and you're not able to type and screen and do all the stuff that they do in the blood bank in forward surgical hospitals, you don't know. So we need recommendations for how many units can you give and go type specific after. In our protocol we say if you start a group O, you continue group O. That's for the pre-hospital guys, because I don't want to have them mix up. So you have to have unit-specific protocols for this. Our protocol is A for A and O for the S, because we are working in small groups, like six-man team. That will improve the number of donors. Larger group, group O only. Safest way to go. So this comes up to the sky, and I think more and more people are using this. And I want to just say it's not only warm, fresh whole blood that matters. A cold chain is important. You can carry whole blood almost wherever you are. So start thinking of making a cold chain. Start preparing your trucks and your vehicles so you can actually carry cold stored whole blood in golden oil containers, and have a fridge in your vehicle so you can go for 14 days. Because here in Africa or in the Middle East and it's 50 degrees outside, it doesn't last that long even in golden oil box. So this is my question for this talk. Do we need to rewrite guidelines for resuscitation of hemorrhagic shock, or is the existing good enough? I believe we might do some changes. I don't know exactly those changes, but we have to at least change the way we're doing this over time. And we have to stop being permissive at a certain amount of time. We have to decide for how long is it safe to be permissive, and then resuscitate to at least above 100. And if they have a TBI, you even have a bigger problem. Because severe TBI, the improved mortality up to 160 systolic. Higher is better. So I'm just going to demonstrate a couple of things because we have been sending cold stored whole blood to the theater now for 2.5 years. using these boxes. I am not funded by Pelican Thermal whatsoever. I have nothing to do with them, but we use these boxes. They come in different sizes. So the way to handle these boxes and how to use them, I suggest for the work group next year, there should be a session on how to maintain a cold chain. If you look at the Rangers, they have both a roll-up program with warm fresh whole blood and cold stored. All the 7 patients they have resuscitated so far, they've used the cold stored whole blood in their cold chain. And that is the easiest. I mean, you don't have to do anything. You don't have to draw the blood. You can just spike the bag and give it. So this is, I have used this on several exercises in the north. This is the last exercise we had. I brought it with me. I drove the car 500 kilometers to Oslo. I put it inside and put it outside. I took it on a plane to the far north, took it out again into the surgical team, to stay inside for 30 degrees and back again. And it took 10 days before the temperature exceeded 8 degrees inside this box carrying 20 units of whole blood. So it lasts a really long time. The problem is if it's too hot or it's too cold. So we tested this. The reason we tested it is we shipped some whole blood to the far north in the middle of the winter, and somebody just places that cold in our box on a tarmac. It's minus 40 outside. How long would it last? It took 22 hours until the temperature was 2 degrees. So freezing cold is worse than very hot. So this is, we are starting shipping 25 units every third day to Iraq in a short period of time. And what happened if this cube are staying on the airport with 50 degrees Celsius? How long does it last? So it takes 53 hours until it exceeds 10 degrees because transport whole blood should stay below 10 degrees. So as long as it stays below 10 degrees during the transport, it's good to use. So in that, so we use, instead of having the bags with the pop, the red and green, we use data loggers in here. This is the data logger for this box this morning. And I don't have to open the box to read the temperature. I have a Bluetooth logger in there, and I have an app on my iPhone, and I just picks up the Bluetooth and tells me the temperature, and it makes me PDF files of the curves and stuff like that. So guys downrange, they send me PDF files of the blood during transport, so we can actually check that it's been within the range, and if by any chance they have been outside the range of temperature, they send the PDF file back home, we look at it and say, the blood is still good, you can continue to use it. So the good thing about the Bluetooth logger is that you don't have to open it. So if it's 50 degrees outside and you don't want to open that just to check the temperature. Here we go. If there is somebody, so I'll just talk about some experience we have with using intraosseous needles. If there is anybody from Teleflex here, excuse me, this is personal opinion. We do research on this. We actually do a study. I'm waiting for results on my iPhone now because we have the last patient today, comparing the fast one, the Talon EZIO sternal device versus IV 18 gauge needle. We take blood samples before, after. We draw a unit of the guy and we reinfuse it the sternal way. So 4 out of 11 talons dislodge it. It's a huge stability problem. So if you're considering buying this device, my advice to you is don't do it. Because if you cough and sneeze and whatever you do, it pops out. We flushed out 3 of them by the flushing procedure, because the flushing procedure is the more important thing to do to have a high flow rate. So instead, we still stick with the good old fast one. And everybody knows that putting in a fast one is fucking hard to get it out, which is a good thing, because when do IV pop out? Every time you move a patient from a litter to an ambulance or a helicopter, that's when you cannot really get the fast one out. So let's see if we can. Yeah, and we also introduced fast one to our hospital, civilian hospitals. So this is a motor vehicle accident, 2 hours post-injury coming in. Nobody could get IV access, so he had red cell plasma platelets for the first 30 minutes before they could gain access on him. So this is why we use this device as our primary non-collapsible vein, because we don't have the time to train or guys that much that they are able to put an IV in a shocked patient. The IV in a shocked patient isn't that easy. So if you want to put IV, put it in as early as possible before he reaches shock. So this is, see if I can make this work. This is flow rate, which is quite good. You can see the flow rate. Happy with that? The gravity only, 8 minutes, 50 seconds, 1 unit, gravity only during a sternal device. So I'll show you another picture just to this is just advice. This is how to remove it. How do you remove it? So the one who produces this says you should just rip it out by the plastic, okay? Have anybody tried that? Anybody has a needle stuck in the chest? You aware about that? So they have previously they had a remover tool, and they didn't want to put a remover tool in again because they needed a new FDA approval. So inside the Fastball, you have the remover tool. That's what's used the Fastball in the chest. So when you use the Fastball, you crack it, take it out, put it in the autoclave, and wrap it so you can remove it. So this is just so it's fairly easy to remove. So after we did that, we have no chest needle stuck in the chest. So it fits perfect into the needle. Take a compass, just wriggle it a little bit. That's how easy you remove it. So, I just want to show you a little other nice device. I was planning to bring it with me to see how it is. So, this is just a coil wrapped around whatever box or whatever you have available to make a coil. Then you go into the Nermus shop here selling what I call a sous vide. You know what the sous vide is? Sous vide is a slow cooker, so that you cook meat with and cook food. But you can regulate the temperature exactly. So it has it keeps the flow going in the water, so it's constant 40 degrees. And it costs about $100. You can buy it anywhere. I just had to test it in the lab. So I work in the lab at the blood bank. So I took a unit of cold salt whole blood. I drew a unit. I took tag and rotam and multiplate and all the stuff I could do. I run it through that improvise, because we always say don't improvise. Please don't improvise with blood. But sometimes if you don't have anything, you can throw plasma in that and you could heat the blood. So I run the whole blood bag. It took 4 minutes through there. It was 4 degrees entering the bucket, and it was 38 degrees coming out. So if you don't have a fluid warmer, it's possible to improvise, but you have to know what you're doing. The temperature mustn't get too high, but this keeps a very constant temperature. So while this is going, because this is the last thing I'm going to say, it's going to be a beer stuff after. So this is not only useful, you can use it for blood. Come on. Open it up. And you can use it for beer. So this is for the beer session after for you. It's 5.1 degrees up in here. And just show you the logger. They are small loggers. This is the other logger. If you don't want to send something, a box with a Bluetooth in it, if you ship that by airline and there's a box and a Bluetooth signal, might be someone who's going to stop that box. Woo, it's going to be a box. So when we transport, we use this logger. It's a Libero logger. It lasts for 465 days. It shows the temperature on outside. You just stick it in your computer, and up comes the PDF file with the temperature range, so you can see if it's been outside or if the temperature range or not. This is the electric monitor I showed you. You can buy it on the internet. It's like a glucometer. It's very easy to use. Recommend if you use it. Take the first drop of an IV line, because we don't really trust the capillary yet, because we are doing studies on that to see if the capillary lactate correspond with an arterial lactate in a hypoperfused patient. So be aware that draw blood from an IV This is a rapid test we use for donors. It's HIV, hepatitis B, hepatitis C. It takes 5 minutes, but it's not FDA approved. But we use it anyway because the best there is. So, and we don't need FDA approval in Norway. We need it to be CE marked, and it's not CE marked yet either, but we still use it. I don't have anything more to say or show you, so open up for questions. Oh, silence.
The one question is begged from your discussion about rapid sequence intubation and his oxygen level. A lot of people will intubate because, oh, my patient's getting hypoxic and it might get hypoxic. Can you talk about maybe what kind of peripheral...
But are you sure you're going to fix it by intubating that guy?
I know, but so what kind of oxygen saturations would a medic be comfortable with tolerating to postpone intubation for the reason of hypoxia?
Everybody hear that question?
I think that will depend on the clinical evaluation of the patient. How much does he have a breathing difficulty at all? Is there any airway trouble at all? So no matter how you explain this, it's like it is perfusion that is the problem. So a SAT like 89 in SAT, if he is breathing okay, so I will not set a cutoff on SpO2, because if you look at the equation, and you put the numbers in there and you go from 100 to 85 and see how much lower the oxygen delivery level is, it's not that much. If you take cardiac output down by 2 liters, there's huge difference. So I mean, flow means more than oxygen saturation. At some point you probably, but you have to, so what is the reason for the DSAT? Is there anything you can do for that? I mean, to jump on an intubation first thing just because your SAT is below this or that, at least that's not my, and we don't carry intubation SAT. So still, our philosophy is that if you're in a tactical situation, like you're in a tactical field care, and then it comes into prolonged field care, but it can always change back to care in the fire again. So what would you prefer then, having a surgical airway or an intubated patient? You could put a surgical in there and he can still breathe. So I prefer surgical airway on top. Because then you can move the patient, you can carry him. If he's intubated, he requires more sedation. You have to sit on that guy all the time. If he has a crike, he can still breathe. Stop the bleeding, keep them breathing, keep them warm, communicate, and keep moving. That's the 5 things you need to do.
I agree with you. It's just there's a big amount of muscle memory that medics have to unlearn because they get,
So don't learn them RSI. Don't learn them RSI. It's dangerous. That's personal opinion, because you need to do it so many times to be good at it. So you will have failed intubation, and if you, by the way, have a small pneumothorax, you make it into a tension pneumothorax. In 10 minutes, you have a cardiac arrest.
Hey, sir, on my civilian side, we end up using CCR, which is basically for the first couple minutes of a cardiac arrest, we put a mounted breather on them and we treat them, and then we move into ACLS. Have you seen anything as opposed to with shock states in trauma patients, is putting a patient on high flow O2 as opposed to establishing and securing the airway?
So the question relates to using high flow O2 in a resuscitation versus securing and establishing the airway.
So like in the CPR scenario?
Yes.
Yeah. I say that will be, we've not used it yet back home, but so if you look at the protocol for CPR, it says normal ventilate.
Yes.
There is no reason for that. There are absolutely no data for normal ventilation in a cardiac arrest patient. They have probably 1 to 1.5 liter of blood going through the lungs. So why do you need to normal ventilate them? But high flow oxygen. So I have a study from Germany from 1952, and it's called apneic oxygenation. Volunteers, general anesthesia, relaxed. They put a oxygen down below carina 250 milliliters of oxygen flow through that. No ventilation. They were stable for 52 minutes. So your ventilation is only for getting the CO2 out. I mean, if there's no production of CO2, there's no CO2 to get out. So, and don't be afraid of that acidosis, but you're going to fix that after. I mean, the acidosis during the shock phase is not going to be fixed by ventilation. You're never going to manage that. So this is in the period, it's in the shock period. I'm not telling when you have control, surgical control, something different. But in that phase of care, if you must intubate, please don't normal ventilate. Just slow down, because if you go from 12 to 6, the venous return to your heart is improving. There's a lot of data on just that. So then you have higher cardiac output, and that is what kills you. Low cardiac output is what kills you when you're in shock. It's not the ventilation that kills you, or lack of.
And that makes the shock state worse.
Yeah, sure. Yeah. Oh.
Geir, do you have any data on the blood flow rates through the tibial or femoral iocytes?
We don't, because we only use the sternal, Neil, but so I know Stacy, is she here? She at least did one cadaver study showing that the sternal, that is why 300 mercury overpressure, the sternum was 1.6 higher flow than humerus. You can easily do humerus, but we don't teach that, because we teach only one thing, the easiest thing, and the sternum is always there. If the sternum is not there, you don't need a sternal device. So you can always use it. So that is why you have to tattoo your blood type behind your ear, because if my processus mastoideus is gone, I probably don't need blood. Question?
Here, just a comment on blood warming.
Yeah.
For as hard as we work to warm up the blood or whatever resuscitation fluid that we're using, we must pay attention, of course, to the ambient temperature and the distance of the line between the warmer and the patient.
Sure.
Because the long and short of it is you can go to Great Lakes with your coil, but even that single line, if stretched out over 6 or 7 feet in cold ambient temperature, you'll cool it back off.
Yeah, sure. So I'm not recommending this. I was just saying it is a device. Actually, Justin Manley, a surgeon who had a presentation at last year's committee, he actually used that blood warmer for 6 months in the deployment, and it worked very well. So then I have to test it on the blood bank to see if it's good for the blood to go through that. So that was the reason I showed it. So credit Justin Manley. He's not here. Justin. All clear?
Any other burning questions?
Take on that point, in your opinion then, which is better, cold blood or no blood?
Cold blood, of course. So you saw the data from Korea? Do you know when the blood warmer came? 1967. This was 1952.
So you'll accept
20 units of, so they have, if you read the old paper from Korea, so most of those papers say the oozing problem comes after 20 plus units of cold stored whole blood. They say nothing about hypothermia in these patients, but might it be that this oozing was due to hypothermia more than, the question with the cold stored whole blood is how good are the platelets for how long? We know that for 10 days pretty good, but we have data showing that even after 35 days with a CPDA blood, the TAG is normal. And you cannot have a normal TAG without any platelet function. That's impossible. So it means that there's still some platelet function in 35 days old CPDA. And that's the other thing. We shift, so you have, your batch you have here is CPD. That's good for 21 days stored cold. CPDA is 35. So for the cold chain logistic is a nightmare with CPD. So I think they are now changing to CPDA. That's what we have done, at least when we go to resupply. We just said we need to use CPDA to be able to store it longer. So but we don't have data on leukofiltration of CPDA. We only have that on CPD. So we're going to do a study on leukofiltration of a platelet-sparing filter on CPDA and see how that works. So we cannot use that before we have the data.
And the Burgundy ambulance is giving the blood clot.
Oh yeah, and All helicopter emergency services in Norway are carrying some kind of blood products. Freeze-thaw plasma red cells. Bergen has been using cold stored whole blood for 1.5 years, and they give it cold because the fluid warmer is still not approved for that helicopter. It takes forever to have a new device in a helicopter. So we say colder is better than nothing, because that's what they did in the previous wars. They didn't have a blood warmer, and the result that they had in Korea was pretty good. So, and 1 unit of cold stored whole blood drops your temperature by 0.2 degrees Celsius. 0.2 degrees Celsius. So hypothermia prevention is even more important in those cases. Yeah. Doesn't anybody disagree with what I'm saying?
How could we? We're scared.
She's scared.
So have you done any studies about on a trauma patient giving oxygen, how many liters per minute? Is if there's a difference between 6 liters per minute and 15 liters per minute?
Are you talking spontaneous breathing now?
There's a proposal going forward right now. Denver's going to start looking at normoxia in trauma patients, opposed to hyperoxia. Kind of like what they did with cardiac arrest patients. So that's out there.
Okay.
Proposal put forward to study hypertensive resuscitation, how long is too much. There are things.
I know. Yeah, okay. Yeah, giving oxygen to people with coronary artery disease and having a heart attack, it goes worse if they have a lot of oxygen and spontaneous breathing. So yeah, oxygen can be toxic, but I don't have an answer to that. So.
No oxygen on the X.
No oxygen on the X anyway, so we don't carry oxygen. Okay.
That's another one for the books. Make sure to go to the site, www.prolongedfieldcare.org. Post your questions, post your comments, make your voice heard. This is Dennis for the PFC Podcast, out.